Today I'm starting gastroenterology recordings of my revision lectures, and I'm obviously quite excited to start gastroenterology because really this is where my current research in pancreatic or biliary cancers, the surgery really is based on. So I feel quite pleased to be moving on to gastro. And in doing gastroenterology, I think I would like to briefly cover anatomy, the GI tract, anatomy, and this will be the very simplified. Sometimes my spelling is so atrocious. Simplified anatomy, just to show where the layout of things are, and then from there on I'll very quickly move on to pathology. The reason why I prefer to do it this way is because I've always been feeling as though I spend so much time in anatomy, and I feel as if I'm quite confident in anatomy, which really means that I don't need to be revising anatomy as much as I have done perhaps in respiratory medicine and in the musculoskeletal system. So I shan't cover a lot of anatomy. Instead, I shall just briefly show a layout of the GI tract, particularly from T10. Really, I'm actually just going to look at the abdominal cavity, and then the structures at the mouth, I shall look at them. I will look at them when I do ear, nose and throat. And from T10, I'll obviously be looking at where the esophagus enters the abdominal cavity. And I think I shall start now. So the GI tract starts at the mouth to anal canal. It's the histology of the GI tract. Histology is quite similar throughout, in the sense that we have we have a mucosal layer, and then we'll have a submucosal layer, and then we'll have a muscular layer, and then finally the serosa, which is the outermost serosa, which is the outermost. So this is from the lumen, really. This will be our lumen there. And the mucosal layer has epithelium, which is squamous in the esophagus and columnar throughout elsewhere. So when I say columnar, obviously it's like tall, and we'd really call it it's a single layer. And really, this distinction becomes quite important, and it will become quite important when I look at pathologies, particularly Barrett's esophagus, where there is metaplasia from squamous epithelia to columnar epithelia due to the gastric secretions from the stomach. regurgitating back into the esophagus through that lower esophageal sphincter, which is not a very effective sphincter for various reasons, really. And it leads to a common condition that we describe as heartburn, really, which is the gastroesophageal reflux disease or disorder. So then this is why I'm really specifying that in the esophagus is the squamous epithelia, which does not have that protective element of being able to withstand the gastric secretions that are found particularly in the stomach. So the epithelium as well in the small intestine, it has a microvilli, which really is a brush border. So really, if we were to think that there will be like the tall columnar epithelium like that, and then the brush border will be there, and we call that the microvilli, albeit that the villi will be looking like this in the small intestine, with that layer of columnar epithelia. I shan't do all of them really because I shan't have so this would be the columnar epithelia, then this is the microvilli there, which are the brush border. Really, we call them the brush border or microvilli. So that's what happens in the small intestine. And after the epithelium, we will then have the lamina propria, and then we'll have the muscularis. Again, the lamina propria will have connective tissue. I'll just write CT. We'll have connective tissue and cells such as resident macrophages. It will have fibroblasts, elastin. Anyway, it will have that. And then the muscularis layer of the mucosal layer will have, this is simple visceral muscle, really. This is just simple muscle, really. And that muscle layer there, which is found in the muscularis, is responsible for the movement of the villi in the small intestine. So that's what it does. When it contracts, when this muscularis layer of the mucosal layer, when it contracts, contraction causes the movement of the villi. So the villi will be, moving. So contraction is responsible for the movement of the villi. And then from the mucosal layer, from the muscularis, we then have the submucosa. And the submucosa really, again, has connective tissue, and it also have lymphatic nodules, lymph nodules, which contain lymphocytes and resident macrophages. Again, the blood vessels, and then the muscular layer on there will have saccular and longitudinal muscles, which are responsible for peristalsis. So this is responsible for peristalsis, which is obviously movement of the food bolus, the food that has been ingested all throughout the GI tract. And then the serosal layer is the outermost layer. It will have, again, a visceral peritoneum. And it will also actually have loose connective tissue, which again has fibroblasts, elastin, blood vessels, and etc. etc. And then, so this is the general layout of the GI tract. It's similar all throughout, and yeah. I know I forgot to say there's a mucosa there. So anyway, this would be the general layout, very simplified, the layout of the histology of the GI tract. So now that I've had a quick discussion of what the histology will look like, I'm also very briefly just going to say, I think I've just thought about this now, that really in discussing this, I think I'm going to separate the GI tract into the foregut, the mid-gut, and the hindgut. This is really to simplify things for myself as I'm revising, and also because of the importance of the blood supply, because really this really also, you know, sort of like links in with the blood supply and makes it so easy to remember the blood supply of the GI tract. For example, the foregut receives all of its blood supply from the celiac axis. All of it, the entire GI tract obviously is supplied by the abdominal aorta, but the foregut receives its blood supply from the celiac axis. The midgut receives its blood supply from the superior mesenteric artery, which really is just abbreviated to SMA. And the hindgut receives its blood supply from the inferior mesenteric artery. So the foregut really, in terms of just from the abdominal cavity, will obviously include the esophagus. I must mention that really I'm looking at the abdominal cavity only for this simplified introduction to the anatomy. So it will be from the esophagus, the stomach, and the proximal duodenum. And then the midgut will include, actually the foregut will also include the accessory organs, what we call the accessory organs, and this will be the liver, the spleen, and of course the pancreas. And of course the liver goes without saying, with the gallbladder as well, because all of these structures are found in the abdomen. And then the midgut will include the distal duodenum, the jejunum, ileum, and the ascending, the cecum, appendix, ascending colon, and the proximal transverse colon, whereas the hindgut will then be the rest of the distal transverse colon, the descending colon, the sigmoid colon, the rectum, and indeed the anal cavity, the anal canal, particularly the proximal aspect of the anal canal is supplied by the inferior mesenteric artery. Obviously, the distal part receives its blood supply from the iliac, like as the abdominal aorta bifurcates. So that's where it receives its blood supply from. But obviously, the proximal part receives its blood supply from the inferior mesenteric artery. So really, I'll just get on to you, just very, very quickly showing where everything lies, and then specifically focusing on the foregut. So really, because this, I'm going to base this on, the diaphragm will be, let's just draw it as a dome like that. And at level T10, the esophagus enters the diaphragm at the esophagus hiatus, which really is just an opening on the diaphragm. This is the diaphragm. And it enters there. And let's remember, the esophagus runs from C6 to T10. So as it enters the abdominal cavity at the level of T10, we have the lower esophageal sphincter, which really is just a muscle that's supposed to act as a valve to stop the contents of the stomach regurgitating back into the esophagus. And then that lower esophageal sphincter leads to the stomach, which really is, is described as a J-shaped organ. And really, the stomach has a greater curvature and a lesser curvature. And while it's similar to this, I'm sure that obviously this is not drawn to anatomical scale or indeed being anatomically correct, but it's just for illustration purposes. And then from the stomach, we'll then have the duodenum, really. However, there is a sphincter there, which is called the pylorus sphincter, which is where the stomach really ends and where the duodenum ends. The duodenum is part of the small intestine, and really it's the shortest part of the small intestine, and it forms a C shape, and part of it is retroperitoneum, really. And then it extends into becoming what we call, it extends posteriorly, really, to become retroperitoneal. And then at the duodenal junction, it becomes the jejunum, really. The jejunum. And then the jejunum really is that part of the stomach which then continues into the ileum. It has a lot of folds, and it's I'm not drawing anything, to be anatomical correct or anything. I'm just for illustration purposes. So this really is the jejunum and the ileum. I almost said ileum and the ileum, which terminate at the ileocecal valve, which again is a sphincter, really, that just stops the backward flow of food, or of gastric contents back into the ileum. And really, as we know, valves really allow for just one-way movement of material. Then the large intestine starts at the cecum, and really there is an appendage there which is called the appendix. Obviously the right lower quadrant of the stomach. So from the cecum, we then have the ascending. The ascending colon, which then makes a sharp turn towards the left at an area called the hepatic flexure. And then it becomes a transverse colon, indeed running under the stomach there. And again makes a sharp turn there at the splenic flexure. So this would be our transverse colon there, making a sharp turn at the splenic flexure, and then becoming the descending colon. And then the descending colon then becomes the sigmoid colon, which sort of runs more centrally. And then, so that would be the sigmoid colon, and then the anal cavity there. Oh, sigmoid colon, then rectum and anal cavity. So this would be AC rectum, SC, then the descending colon, and this is just the transverse colon. So really, part of the foregut is all of that up to there. That's the foregut. Again with the accessory organs